Good afternoon, everybody. Welcome. This is Ken DeSercio. I'm the Deputy Project Director for the National Quality Improvement Center for Collaborative Community Court Teams. And welcome to today's webinar, Strengthening the Ties That Bind, Part 2. We're glad you could join us today. A couple reminders, if we could move forward. The National Quality Improvement Center for Collaborative Community Court Teams is a program of the Children's Bureau, the Administration on Children, Youth, and Families, and the Children's Bureau. A couple housekeeping items. If you can see the screen, then you have the instructions for how to join the audio to the high-def conference line. If you're on the phone and having trouble accessing the Adobe Connect and not able to see the slides, you can call us at 1-866-493-2758, extension 8965. If you're having difficulty connecting to Adobe and you need some help, and that's Michael Franzen. Feel free to use the chat feature at the bottom of your screen. We'll take questions that way. We have a small number of participants today, so maybe we'll even be so bold as to open the phones up later. But you can see the chat screen, the chat dialog box, if you will, on your screen. So feel free to post questions or comments through the chat screen. We'll be monitoring that over the course of the presentation. Several weeks back, Dr. Katz presented part 1 of this 2-part webinar series, Matching Services to the Needs of Families. In that first webinar, Dr. Katz presented a framework to help collaborative court teams assess the needs of families, identify which parent-child interventions are best matched to families, and provide timely and coordinated services. Today's webinar will address strategies to strengthen care coordination, communication, and information sharing. So this is part 2 of a 2-part series. Collaborative court teams, as you know, must work with community service providers to decide what information needs to be shared, with whom it needs to be shared, when it needs to be shared, and how best to share that information. It's even more challenging, I want to say in this day and age, but it's even more challenging with the depth of services that families are receiving from multiple human service agencies. And later on in the webinar, we'll talk about information sharing between the court and service providers, children's providers, substance use disorder treatment providers, as well as child welfare. And with the implementation of plans of safe care, now we also have the challenge, if you will, and the opportunity to share information, particularly to share plans of safe care among the agencies and the service systems that I just mentioned, but also with healthcare providers, maternal and infant healthcare providers. This webinar will highlight the key components of effective communication and information sharing approach, and Dr. Katz will provide examples from the work that she's done at the Linda Ray Center that court teams can use to improve their system of care. It's my pleasure to introduce Dr. Lynn Katz, University of Miami, and let me just give you a little bit of background on Lynn, if you will. Dr. Katz is a research assistant professor in the Departments of Psychology and Pediatrics at the University of Miami. She's the director of the university's Linda Ray Intervention Center for high-risk children ages 0 to 3 who were born prenatally, drug-exposed, or were victims of child maltreatment. Since 1993, she has coordinated the program's comprehensive early intervention services for over 1,000 infants and toddlers and their families. She was the early childhood partner who assisted in the development and ongoing implementation of Miami's dependency drug court services for children and parenting, and has worked extensively with the National Drug Court Institute training of new family drug courts. Lynn is also the co-author of Child-Centered Practice for the Courtroom and Community, a guide to working effectively with young children and their families in the child welfare system. And with that, I'd like to turn it over to Dr. Katz. Lynn?
Thank you, Ken. Thank you, Ken. It's a pleasure to be here. I love the way these webinars can bring everyone across the country together. For those of you who are in sites around the country, I'm talking to you from Miami, Florida, and we have our whole team of our California people at Children and Family Future. So let's begin, if we can. What we want to do today is connect the discussion that we had about 2 weeks ago, in which we talked about matching services for both the children, the adults in the family, the support system of the family, so that we can always be family-centered in our care. But the fact is that once families are connected to services, we have to, from so many disparate locations and sites and providers, we have to coordinate the information that's coming in to us as a court team, synthesize it, prioritize it, and find out how to share information across the various structures of our governance, if you will, of our drug court team. And in order to do that, we should think really simplistically. What is the information that we're typically going to have as we're moving forward with one of our families and their cases? What's the need to know level about information? What are the barriers and the infrastructures within a given agency or provider or the court itself that sometimes hampers our ability to exchange information? And what can we put in place in terms of infrastructure to allow that to go more smoothly, all on behalf of our family-centered care approach? So this seems like information sharing 101, but it's always important to go back to the basics. When we share information appropriately and we protect where we need to confidentiality and privacy of our families, we can develop a more complete picture of what's happening in terms of the progress of our families, the adult caregivers, the children, where are we with treatment, where are we with mental health services, the educational pieces that our families are pursuing, and also all of the individual needs that are developmentally appropriate for the children in these families. Well, we need to be able to integrate that information. And as all of us know who work on court teams, it comes in, it's fast, it's furious. We need to find ways to look at it, who needs to look at it, who has to be at the table, what do we need to design so that that flow goes back and forth in a very coordinated manner, and then also to how do we synthesize all that information for our decision making so that we can really document the progress of both the adults and the children and the barriers that we anticipate, and then how do we bring all that information into the court setting. The more informed our decision making is about what's happening in our parent and our children's lives as we work on an individual case, we're going to get both quantitative information about the members of this family, qualitative, anecdotal information, and all of these pieces of information will guide us towards our decisions about where are we moving in terms of permanency. Is the family ready for unsupervised visits, weekend visitation? What are we doing in terms of thinking about reunification? And also, does that information also inform us if, in fact, we've come to a barrier, a ditch we can't cross, and we have to think based on the information we've received about whether there has to be an alternate case plan goal, and whether our goal still is reunification as our ultimate permanency solution. Well, I love this cartoon because across our agencies, between our agencies and the court, within agencies, there are a lot of tugs of war about what can I share? What can't I share? What should I talk about verbally? How do I protect my client's privacy, but at the same time, knowing that information needs to be shared? And we are bombarded all the time by what our discipline tells us. So if we are a clinician, our practice model will tell us what we can and can't share about discussions with our clients in a clinical setting. Attorneys will tell us what we can and can't share and how to do it. What about the forms of communication? When should we send hard copy documents? When should we fax? What can be sent electronically and what are those protections? And so we all have our procedures, but if they continue to stay separate, we can't integrate the information in a timely, competent manner. And as you see, we even have silos here. So we have our individual turfs. We know what it takes within our agency to share information amongst the various partners within our information. But as soon as we venture outside our silo, we venture outside our agency, we need to know that everybody on our team understands who can be shared with what and how it can be shared. And that information sharing is really grounded in the relationships that you've established for your team members, for those providers you work with, for anybody who's touching the family that you are working with in your collaborative court model. You've set up relationships, and those relationships, we hope, will continue to be grounded at the agency levels in an understanding of trust, an understanding that everybody has the same goals in mind for this family, and we protect what we share with our professionalism and our honesty. But sometimes it takes more than that to be sure that what we're sharing doesn't cross any boundaries, if you will, and still protects the families and who they are and the information we need to know. So let's continue. There are different types of information, and all information involves, for the most part, what are the implicit confidentiality aspects of sharing that information? How do I receive that information? Are there barriers based on my clinical practice about what I can and can't share, as I mentioned before? And then when I'm going to court and I'm providing not only my written report, but perhaps a discussion about what the report contains, how do I share what needs to be shared, don't challenge certain aspects of confidentiality that are part of my best practice, and how do I, in the sharing of information across providers, particularly in court, how do I preserve the provider-client relationship? Is always something we have to consider in terms of information sharing. And of course, we think of treatment reports, mental health information as the most sensitive. But at the same time, if we're sharing information about the functioning level or the cognitive ability of an adult or a child, we have to share this information delicately and make sure that we have forewarned our family what it is we need to talk about and why, and that we speak to their attorney if necessary before presenting anything from our perspective in court. The rationales for the fact that we need the assessment data, we need the evaluation data, we need the qualitative reports from treatment providers about how treatment is progressing. We need to know if someone is being compliant with their meds. We need to hear that piece from the clinical person that they are working with, because if we can't share information and do it appropriately, we're going to lose that connection with our family and with our clients. And then we also want to know that across our agencies as we work together, we're on the same page and we've had discussions about what we're going to, quote, testify about before we go into the court setting. There are different types, of course, of information, and I think as you're listening to this, you may already be thinking about what you are faced. So there might be assessments and evaluations, and that data is private, is important information about who that child is or what the psychologist has said about that child. And so, again, think about the barriers you have, and I'm going to pass this to Ashay so we can do our first poll question.
Thanks, Lynn. So we have our first polling question. The question is, what is the greatest barrier your team experiences related to information sharing? Is this confidentiality issues? Quality of information is lacking? Information is not systematically collected? Are there issues with timeliness? And the last one is, who has the need to know about which information, and does this connect to your governance structure? So if you all can use the pop-up box to put in your answers, and then we'll collect them and look at them in about a minute. Okay, it looks like we have about 15 responses, and it looks like most of you noted timeliness as the biggest barrier to information sharing. So this is timeliness of receiving information for court hearings. All right, I'll pass it back to you, Lynn.
Yes, I don't think that comes as a surprise, actually, because I'm sure we've all experienced the notion that we're gathering the pieces of information that we need. We're pulling things together, for example, for a judicial review or a hearing. And the fact is, we can't write our final report because we're missing information from the treatment provider or from another clinician, or we haven't heard from the parenting time coordinator with their report, and it is always a discussion that we have across our disciplines. What do we need to put in place to receive information at the central depository, which is potentially your court team, in which you're pulling together all the information to be able to go to court? And I'm thinking, as we start with the chat, that some of you may have ideas about how you've overcome this. How do you set your deadlines in terms of the expectations of when you need information that's going to maybe be integrated into a larger report, and do you set those deadlines early enough? And who do you need to speak to if, in fact, the very person at that provider who's supposed to get you that information systematically waits till the last minute? That's really very difficult. It takes a really hard but frank conversation in one of your court team meetings to talk about what do we need to do and how can we set some standards of when we need information. Because typically what we would do in Miami is have as much information as we can prior to going to court, well in advance, and I say that optimistically, so that we can have a staffing, which is what we call a meeting, where we bring everybody together who is working as a frontline provider, for example, on this case, and we share that information about where things stand with that client, with that family, with the children in that family, well in advance of going to court. Because part of what may happen at that moment is there is some information that comes into your court team that may or may not yet have been shared with the family, with mom or with dad. And we need enough time to be able to tell our participants well in advance of sharing that information in court what it is they can expect that the group dynamics have been and what it is that we are going to to share in the court setting. My clinicians tell me all the time that whether the information is good that they're going to share in court or whether it's something that still needs work, the only way to preserve their relationship with their client is to be able to have that dialogue well in advance, to be able to process it with the mom, with the dad, whoever it may be in that respect, so that there are no surprises and nobody feels like they were blindsided when they go into the court setting, which is always an issue. I can remember situations, and you may have had that, when we didn't get information in a timely manner from a provider, and the provider then arrived in the court setting to share that information, and it came as such a shock to the rest of the group that the judge made us sort of take it outside and take a breather so that we could react to information that came in to the discussion very late. Now, part of what we all ask ourselves is, does everybody need to know everything about the case? And I think that's a discussion that every court team is actually dealing with. You know, who needs to know what and at what time in the discussion? What are the mechanisms, such as ongoing staffings or conference calls, where pieces of information are discussed across the provider, the partners in the team, so we get a sense of where we're going before we hit a court hearing, and we're constantly in the loop with each other. And I would ask you, as a court team, do you have hierarchies that you've set up about who comes to most of the meetings? Are they done by conference call? Are they done in person? When do you always bring all the attorneys to every staffing that you have? These are some questions that you may be challenged with right now, and you want to be thinking about in your infrastructure.
So this is Ken again. Thanks, Lynn. I'm going to talk for a few minutes around some of the pathways of communication. This is not easy work, folks. As Lynn's describing, the title for today's webinar, Strengthening the Ties That Bind. When I think about that, I think of two things. I think the mission of what we're trying to accomplish collectively as core teams, as those of us that do this work, in terms of the mission of improving outcomes for children and families, as one of the ties that bind. But care coordination and information sharing is the other tie that binds, if you will. And it really becomes kind of the glue that makes the difference between operating as a team to improve services, to improve access to services, to improve outcomes for children and families, versus compared to perhaps, I wouldn't say the previous way of doing business, or doing work outside of a team environment, if you will, and that is individual providers providing individual services within individual silos to individual family members. It's not necessarily family-centered, and that very few parties know about what's going on. The core team has an opportunity to come together and answer these questions in a formal way. Most of you, probably all of you, have relationships among the various agencies that you've worked with over the years, and so there's a tendency to rely on that informal communication, that informal relationship, or if you will, in order to communicate the areas, some of the content that we're speaking about today. And what I think part of the message today, and part of the challenge of the core team, is to move beyond that and to formalize what those communication protocols need to be. And so these next two slides come from what we call pathways of communication templates, and they're designed to help staff move beyond preliminary discussions about communication and toward developing the communication protocols I've been describing. What you're about to see in a different format, though, was published originally in the SAMHSA National Center for Substance Abuse and Child Welfare document, what we call SAFER, Screening and Assessment for Family Engagement, Retention, and Recovery. And these are intended to be suggestions for each community to work out, but prompts, if you will. And there are three components to the communication pathway, and we're only going to talk about one of them today. But you can see on this slide the importance of the communication pathway is the need for a coordinated response in working with families, and an understanding of similar or parallel procedures that may be going on among the various systems serving families, and the need for formal and clear patterns of communication. During these three distinct stages, stage one, determine the presence and immediacy of an issue. In the work that I've done, my background is as a substance abuse treatment provider, and in the work that we've done around the country in working with sites, I can't begin to tell you how many times there's frustration around how information is shared. Child welfare makes a referral to a substance use disorder treatment agency for an assessment. Child welfare has a fair amount of information on the background, perhaps prior reports of maltreatment, whether they're substantiated or unfounded, related to parental substance abuse. They send a person over for an assessment, and they get back, no treatment needed. And oftentimes when we begin to ask the questions, what we find is that there's a lack of formal level of information that's being shared. And so what happens is there's frustration around the kind of back and forth, if you will, or teaming when inadequate information is shared. And as you see in these arrows, it kind of goes, the arrows point just about every which way. But the example I gave is in one direction, from child welfare to an SUD treatment agency, but it also works in the other direction as well. So stage one, determining presence and immediacy of an issue, and who needs to know what in order to really assess what's going on with the family. The second stage, determine the nature and extent of the issue and treatment and case plans. And this essentially is, Lynn mentioned, coming together as a team and doing joint staffings. And this is really kind of coordinating what a case plan would look like in child welfare and what a treatment plan would look like in substance use disorder, mental health treatment, and now what a plan of safe care would look like, and the information and the services that we outlined in a plan of safe care. We're going to spend the next slide talking about stage three, monitoring change, transitions, and outcomes. And that's why monitoring change, transitions, and outcomes. This is a critical function for the court team to establish these protocols around this area in particular. So can your team and can your court answer these questions with the level of information that you're currently receiving as a team? And so are there demonstrable changes in the progress of a family making in the services that they're receiving? Are there standardized reports that include objective measures of progress? And the more objective they can be, then the more transparency there is around the type of information that's being shared. That's often a challenge to translate what might happen in therapy sessions and clinical work into objective progress. When we look at transitions, is the family ready for transition? And what happens after discharge? This is really important. How are changes in services plan, in case plans, and plans of safe care, and treatment plans? How are changes coordinated? If there's a change in the permanency plan, how is that information coordinated? And then how are treatment and court discharges, service admission and discharges, case plan closure discussed and coordinated in advance. To give another example, as that I hear from treatment agencies around the country from time to time, is frustration and then be working with a parent, working with a family, and a case will be closed, child welfare case will be closed, certainly for appropriate reasons, but the clinician may not know, hasn't been informed that the case has been closed, and all of a sudden the parent discontinues treatment and services and just doesn't show up, and sometimes triggered by the fact that their case has now been closed. And so coordinating those transitions, and particularly case closure, discharge from the specialty court, case plan closure, as well as discharge and completion of services. And ideally, and you really want all of those benchmarks or milestones, if you will, to be discussed in advance, and so that everybody's on the same page about when those transitions are going to occur. It gives therapists in particular an opportunity to engage their clients around those transitions, to have those discussions, prepare them for those transitions, and then hopefully keep them engaged, particularly if, in the example that I gave, if a child welfare case is going to be closed. And then related to outcomes, do the interventions work? And a lot of the focus that Lynn has presented several weeks back, and it was around really understanding whether the interventions are matched with families, and what do we know about those interventions working, and addressing the issues that brought a family into the court, into the child welfare system. Do we see improvements in those? And Lynn's going to talk about that a little more. And what we're working with all of you in Quick through our evaluation liaisons is is helping your team and helping your court monitor both child welfare, substance use disorder treatment, and children and infant outcomes. And then when we talk about that, how is that information put together so that you really have a more complete picture as to how the family's doing, and then a more complete picture of how your system is performing relative to those cross-system outcomes.
Ken, this is Lynn. If I can say something,
Yes, Lynn.
if I can just sort of piggyback on something, and I think it also fits into what I'm seeing in the chat box from Mimi Laver, asking, how do attorneys fit into this model? And what we have found over time is the more accessible the attorneys can be working on a case, whether it be the parent attorneys or the guardian ad litem attorneys, on behalf of their clients, the more accessible they are, and the more, if you will, evidence we're able to give them about what we are thinking is the parent progress from a clinical perspective. The more information we can give them. So, for example, that's why we always talk about documenting and having data for anything that you're going to ask a client to do. What is your justification as to why they need to do that? How will we know when competency has been achieved? What will we do sooner rather than later if something that we have recommended, and we talked about this in part one, is not helping the client, whether it's the child or the adult, reach their goals, not to wait to the last minute, have documentation, and we say it has to be documentation that is either quantitative or is based in fact. It can't just be subjective. I think the client needs a little more services. Well, based on what? And we have found that in developing relationships with all the members of the team, and in particular the attorneys, if we are providing them with quantitative information about this is what the evaluation meant, this is what the prognosis is, this is the match with the service that should get your client to that point, or that child to their improvement, and documenting the progress, not just at the end, but along the way. We're going to talk about how to do that documentation, that we are able to keep attorneys engaged and understanding that we have the same goals. So I think Mimi, we're going to talk about some of the things in a moment that have worked and which are appreciated by both the attorneys and by the judges, that we get down to the brass tacks of expectations, how we're going to get there, how much time we anticipate it will take, letting everybody on the team converse and know if our decision to move forward with this intervention turns out not to be the right one. How do we fix that? But we don't blindside anybody, and we provide information on a very regular basis to all the members.
And Mimi, you raise an important point before we move on too, is that these communication protocols that we're speaking of about formalizing really need to be done with attorney engagement. Most of the sites, most of you out there in the quick sites brought an attorney, child welfare legal services, dependency attorney, parent attorney, if you will, children's attorney, GAL, to the all sites meeting. You really have to develop these communication protocols, how you're going to address confidentiality with the engagement of parent attorneys. We've worked with several specialty courts, several drug courts that were developed kind of in the absence of attorney engagement, and you can imagine what happened. And no referrals. The attorneys didn't agree to recommend that their clients participate in the family drug court. Issues around confidentiality, issues around how the information would be used within the court in terms of the progression of their case. So absolutely, even though the chart kind of implies it within the court, it doesn't clearly specify attorney engagement, but it's really pretty fundamental to engage your attorneys as you're developing these protocols, so they understand the information that's being shared, how it's going to be used, who's going to have access to it, and as Lynn said, being able to demonstrate that through a collaborative, through a community collaborative court team, that there are benefits, demonstrated benefits, outcomes, if you will, for their client participating in those specialty courts. Lynn, back to you.
Yes. Okay. I think we're ready to go to the next slide, and I think it fits nicely because developing the memorandums of understanding and the agreements in terms of what information sharing will look like and to whom need to have everybody at the table so they can state outright, this is what I'm going to need. And this is information that I can't have prior to such and such happening. We had our judges as part of the planning process when we were saying to them, we're going to develop a system of evidence-based providers, and we're going to start with our parenting time providers. Judge, tell me, what is it that you are going to need to know from them? How specific is that information? What do you want to know so that you can make a decision? And I think that we need to each be taught about what our collaborative disciplines, what they need, what is their goal, their perspective on the goals for this family, what they can and can't share. And so developing an MOU across everybody who's going to be working with the families will have specific limitations. It will talk about how information will be shared, who has the need to know, what is your process going to be. So many times the MOU is just sort of a list of providers, and you check off their names to say that the parent says, I'm okay if you share my information with the following parties. Well, we need to be, as Ken said, really drilling down on what will the MOU say. Let's get it out there. Let's have it as documents that we can refer to so we know what boundaries we each have in that sharing. We've been told in advance, we've had a training, everybody who works at the different court team agencies or in their roles, you've had a training. You understand who can see what format things can be exchanged. Do we send this to a central party at the court? Can I have a discussion with you about this as I'm writing my report? It seems so nuanced, but it's the only way to deal with the minutia of preserving the confidentiality and reaching consensus when we can about sharing, but not having anyone cross the boundaries of their best practice. As we say, we do a lot of our pre-court staffings. We try to have the people who are relevant at that staffing, having that conversation. We don't bring anybody new in until they've understood the boundaries of what this discussion will include and what it won't include. Sometimes, as Ken was showing, you need a flow chart, and everybody needs to be trained in this is what your boundaries are, this is what you can discuss in these settings, and then you keep revisiting it if things change over time. Everyone who is at the table will need some degree of access to information. Your structure is going to determine this may be this type of staffing. This may be another type of staffing about whatever the topics are going to be. For example, in our court in Miami, in Dependency Drug Court, we have an office for the public schools, and we have an agency liaison from the public schools. They're co-located at the juvenile court, and they don't come to every staffing. They are there as needed, and where they can be called to say, we're going to be discussing this school piece for this child. Please come to our staffing tomorrow morning, or we need to have a conference with you as to know what the child's report card is. But we're not going to always have the public school liaison come to every staffing because the need to know basis will switch over time. And I would suggest, we have done this many times, we've had to step back and say, let's look at our information sharing agreements. Let's look at what our flow chart looks like. Have we kept everybody apprised who is new and comes to the table? If not, we need a training for them, a discussion for them. And it's a work in progress, and as Ken said, it's very complex, and it's for everybody's safety and security in terms of the information sharing. So when you're talking about all the providers who are wrapping themselves around helping this family reach their goals, the children and the children and the adults, from an accountability point of view, we need to have some expectations about our providers. We have to get a sense over time as to whether a provider that we are working with around the needs of a family, who is the actual frontline person who's delivering the service of that provider agency. You know, you read the summary, it sounds like that this is what they're doing, it sounds like these are their services, but you're only going to know really at the front line whether or not the actual provider or clinician is providing what the agency said they were going to do if you start thinking about fidelity monitoring. And we need to tell providers in advance when they come to the table, and it's part of that sort of sharing of information, MOU development. This is what we're going to expect to hear from you. This is approximately the frequency of when we're going to hear it. this is the mode, this is the template, these are the key pieces of what we're going to need from you that need to be prioritized in your report. And that's what brought us in Miami to developing some universal templates, because it validated accountability and all providers knew what was expected, and the template included information that we had heard from the attorneys they wanted to know and from the judges that they wanted to know. But in terms of, is the service at the ground level being delivered, implemented the way it was designed to be implemented? That comes from agencies either monitoring themselves for fidelity, using the tools of that evidence-based practice, or potentially bringing in someone from the outside who monitors fidelity, maybe comes in randomly, gets information and has access to look at an intervention file to see how many sessions actually took place. You have to decide, and this is a very delicate piece, as to what is the provider using in-house to assure fidelity that that clinician is developing and using the intervention as it was delivered. This is very, very, very important. And oftentimes you come to these decisions because you have a relationship with that provider and you already know that you both want the family to reach their best services. So we're going to show you some examples in a minute of some templates that we use in Miami to standardize expectations for providers. As far as examples of MOUs, I think if we put our heads together, that's something we would be able to provide to you after this call today. So let's go to the next slide. Shay.
We're at our second polling question, and this is just a very general question about fidelity monitoring. The question is, how confident are you that the programs and interventions your families participate in practice fidelity to their evidence-based model? And we have a Likert type scale. Response options are not at all confident, somewhat confident, confident, and the last one is don't know. Okay, so it looks like we're close to about 15 total again. So our responses are, so we have 0% for not at all confident, 50% said somewhat confident, 28% said confident, and then 21% did not know. All right, back to you, Lynn.
I think this is very telling because somewhat confident says to me, I kind of think, I mean, they're a good agency. I'm presuming that they're doing what they said they were doing. And the question will always be, even your somewhat confidence, what do you base that on? What do you have? What documentation do you have that would let you feel comfortable that the dosage and the information that is being imparted to your client at the sessions of their parenting program are in fact the way that content was designed? And I think it's interesting too to say sometimes we don't ask these questions, and I do have to quote, but I won't say her name, one of our judges in Miami who said, when we started this project decades ago, I always thought that the parents were getting the intervention that we sent them to. And getting that intervention and how it was designed, I never gave it much thought. I I assumed they were getting what they needed and that it would work. And I think we are less naive about that today, and we understand that we need evidence. We need evidence. We need ways to measure whether a protocol is being followed, whether an intervention is being provided. We need that in the world of accountability. So Fidelity has core components. It means to what degree is the provider at the point of contact adhering to the curriculum or the intervention model. Now, that isn't something that's rigid and inflexible, but there are core components of any evidence-based treatment model, whether it's for children or adults, that need to be adhered to with the dosage that is recommended, or we won't get the outcome that we wanted. And as an attorney, I would certainly want to know, if you're sending my client to that program, tell me what they're going to get. Tell me what the parameters of that program are going to be. What are we striving for in terms of the outcomes? How long will it take? And when will I know whether my client is getting closer to those outcomes? I need information that is not just conversation if I'm a lawyer or a case manager. So we always need to know, for that intervention, to the degree we can quantify it, what is the frequency that the intervention and the client, or the intervention and the child, are coming together? With what frequency? How many missed sessions really impact whether the intervention can ever reach the outcomes that you want? What's the, if you don't come this many times, we have to start over again part of the intervention, if such a thing exists. And then how do we know who's delivering the intervention? Because many evidence-based model does not allow for someone who's doing the intervention and is now moving out of town to teach their colleague how to do the intervention. The new person must revert back to the original training from the developer or from their designee, but we wouldn't know that within an agency unless we understood the boundaries. Is this a train-the-trainer model? What is the dosage? What's the frequency? How many absentees mean we need to start again? We need all that at the beginning, because that's part of finding out if our families are getting what we sent them to get. And there are often Fidelity monitoring tools. Some of them are through direct observation. Some of them, the third party or the developer comes to the site and actually watches a session of the parenting program to be sure that the facilitator is still hitting all of the marks that are needed to deliver that information. Because what we know about Fidelity is that people drift. And if I've been doing this for 25 years, if someone doesn't check my Fidelity, I may be approximating the core components of that intervention, but not delivering them the way they were intended. Okay. This is always disheartening. This comes from the NSCOT survey in the last cohort about 2 years ago. And when they looked at the accessibility of evidence-based programs for parents, they found that at that point, less than 2% of the parenting programs that were being used in child welfare were evidence-based. So that meant that at that point in time, 98% of what parents were getting when they went to a parenting intervention was maybe whatever the provider thought they should get, with a dosage that they wanted to do in that timeline. There was no evidence that the curriculum that they were delivering would get your client to the outcomes and why we sent them to that program to begin with. So that percentage is very disheartening. So we are not at odds by asking our providers of services, what are you using, what's the dosage, what does compliance look like, how are you measuring progress? Let's go to the next slide. So this is one of the components that we added to our whole system of care parenting provider network. We said we need to have a number of measures that everybody is using. And this is what we call in the world of research a reliable, valid measure that does have predictive value and does monitor progress. It's called the API. So everybody who goes to a parenting program through the court and the approved parenting network will do an AAPI at baseline. It sort of tells us the levels of risk around important aspects of parenting, and it is scored, and then it is done when the parent finishes the dosage and frequency of parenting programs that they need. It's one of those pieces of data that can help quantify what were we looking at, what were the areas of strength, what were the risk levels of the parent responses, and allows us to enter that as evidence. The next slide, please. And the truth of the matter is that once we started adding measures and evaluative tools to what a provider was giving us in court, it became much more evidentiary. And this was an example, this is going back in 2011, when one of our cases went up to the Court of Appeals. And we were really actually pleased to see that part of the comment section said that although the parent attended the parenting classes, her score on the post-services test led the case manager to conclude that reunification was not a safe option for the child. So this was one contributory piece of evidence, a piece of accountability that was included in the discussions about parent progress along with a number of other measures. But the fact is that it came to the attention and it made sense that the case manager and the team was using evidence in their decision making. And so when we saw this bubble up this way, we thought this usage is effective all the way across our system. Next slide, please. Were we going to show the template of the parenting report?
Sure, yes. We'll pull it up right now. Give us 1 second.
Okay, we wanted to show you this because some of you have asked about whether the reporting templates can be shared. So here it comes. We're going to pull up one example, and the answer is yes, they can be shared. Let's see if we see this. So again, we use this across our provider network in Miami-Dade County. All providers who are doing something to do with parenting, non-clinical, have to create an initial report. Okay, you can, don't move it for a second. And as you see, the instructions in the report to anybody who reads it says, this is the baseline information. We are including the results of the AAPI, the pre, and we're going to summarize also what we saw in the parent-child behavioral observation. And you're going to have these two pieces of data because it's our starting point for the parenting program. And we can slowly, move that down. And the way the report is designed is it has multiple drop boxes. The agency name is part of the drop boxes. We talk about the dosage, here we are, how many sessions, where was it delivered, when did we start it, if things go according to plan, when do we think the client will be finished with this. We give the rationale here for the evidence-based behavioral observation piece, which we do with the young children. That will be attached to this report, and so we would be able to fill in the information about what is going on in the relationship between the parent and child, the quality of their play, the child's negativity toward the caregiver, or vice versa. And attached to this is the documented scoring sheet. And the folks who are doing the scoring have practiced sufficiently that they have a degree of reliability. If myself and that observer were to watch a parent and child play, the range of responses that we would come up with would be reliably within the same range. So this also speaks to training, but it's information sharing. When a judge looks at this report, he or she goes 1, 2, 3, let me look at the baseline scores, let me see what was seen in the observation, the qualitative piece. Now I have the stuff that tells me what the scores mean. I have it in every report that comes from this provider, and this is what an initial report looks like. We also designed status reports that our provider will do every month that the family is in the parenting program. Send them to all of the parties on the case so nobody is surprised how it's going. We also designed a termination report in terms of there's no engagement, the parent has already missed too many sessions. For now, we are terminating the client from this service, and it talks about the team in the termination report having a staffing before this happens, and where are we going to redirect this family. So I have all of these reports. I will give them to Ken, and they can be disseminated.
Can you talk for a moment about how this was rolled out? I'm thinking you have multiple agencies providing parenting services, and they're all using this. Can you talk about how they got trained and who took that on, how that was accomplished?
Yes, I can. And I think what's critical here is the judicial leadership that led this rollout, if you will. First, we brought together everybody who was currently doing parenting. We explained and did training on the value of evidence-based curriculums for parenting training. We then asked for volunteers from all of these providers who would like to help us examine through the California Clearinghouse all of the parenting programs that would be relevant to our community in Miami-Dade County. We met for 4 to 6 months. We looked at many, many parenting curriculums. We, as a group of about 25 folks, we then voted on the top 5 curriculums. We went back to the agencies, and the judge said, and the funder, who at that time was the Department of Children and Families, said, we are within 6 months from now, we are going to ask that if you're going to work with court-referred families, that you get yourselves trained in one of the selected curriculums. And we are talking to some funders who might be able to help you get that training. We are, as part of that training, our team has developed a set of reporting templates that are very user-friendly. They have drop boxes. You do them at strategic times in the case. Our Department of Children and Families, our judges are telling you, this is how we're going to proceed 6 months from now in the new year. And if you want a contract to be a provider of these services, you will need to comply. We will also be monitoring in the first year of this project. We will be monitoring your reports. We want to be sure that you're including all the data that you need. And we provided training we brought the developer of the AAPI to our community. He was happy to come. We taught people how to fill that out. and we trained multiple people at each agency to become reliable in doing behavioral observations. So we had a qualitative accountability piece, a quantitative accountability piece in the AAPI. We had everybody using the same reporting templates, and then we did a training for all of the judges in dependency so they understood what the rollout was going to look like. They understood what the scores meant in both the behavioral observations, and then we rolled it out. So from beginning to end, Ken, I would say that the process to get to where we wanted to go, we were ready to go there between 9 to 12 months later. And we had an integrated, approved parenting provider network. We had people using the selected curriculums that meet the needs of our families in Miami-Dade County. They were linguistically diverse. They were evidence-based. They were for families that had children of all age ranges. And then they incorporated the baseline and post measures, and by that next year, we were in rollout phase, monitoring what was happening, and suddenly information was moving back and forth between the providers and the court members in an expedient, discernible, get to the point approach. As we're going back to the slides, one of the things that I've come to understand over time is that for many communities, they have one aspect of their service provision that they would like to tackle first, if you will, and that is the aspect of their system of care that they would like to improve the MOUs, improve the information sharing agreements, put more accountability in terms of data collection into the decision making that comes from the team, and they've decided what they want to prioritize, because I will say you can't do everything at the same time. We chose the programs, the parenting programs. I'm working with a PFR site right now. They wanted to examine their kinship care component of their system of care, and that is the piece they wanted to revisit in so many of these similar ways, but that was a clear and present danger, if you will, that they wanted to address right away and build these accountability pieces, provide the training, have the exchange of information pieces in place. They, unlike Miami, they weren't looking first at parenting. So, okay, just to get back to this slide, we talked a little bit about it, and then Ken really emphasized it. You need to really be thinking about what sorts of information do you exchange, from what sources do they come, what are the challenges and barriers of exchanging that information, and in what manner should it be shared. Are we talking about sharing raw scores of an assessment? Are we talking about, no, we're not going to share those unless asked, we're going to do summaries of what that evaluation showed across different competencies of the adult? How does your governance structure, your managers, then your frontline folks, perhaps your evaluation folks, what is the structure, and have conversations about who needs to know what and when. Have a conversation, have multiple conversations, agree on your processes. If in doubt, create protocols, because new people will come in every aspect of your team. They will need to be retrained. They will need to understand what the boundaries are. They will need to see the model of how you build your consensus, how you reach consensus for a decision, and how you share information, which may be very different than the agency they worked at before. So what we see is if you can find chunks, if you will, of the services that you are matching potentially to your families, ask questions about how do we develop a protocol? How do we put down in writing what information exchange is going to look like, and how would we coordinate it? For those of you, and the preponderance of you said, there's information to be shared, but we can't get it in a timely manner. Well, how do you come to an agreement about what the deadlines are going to be for the central depositories, if you will, or the need to know people? How are you going to back away from your deadlines to get what you need when you need it? And that's a hard conversation because everybody's working hard. They have a lot of work on their plate. Some people have far too much work on their plate that we are working with out in the community. We don't want to cause a burden for them, but do we want to be able to send them something on their computer that reminds them, in 1 week, we'll need your clinical report, and set some artificial deadlines because you really don't need it for 2 weeks. All of this relates to getting the information you need out of respect to the families, to the parents, to the children, so that you are sufficiently, honestly, and in real time tracking and monitoring their progress, their challenges, and their setbacks. The idea of ongoing meetings is really, really important, and we say meetings, those can be phone calls, and you pull out the sheet, okay, this has to do with this topic, these are the people I need to email, these are the people who I need to do a doodle poll with, and they need to understand it's time sensitive because we need to have this meeting within 48 hours. How are you going to communicate that in a way that's effective rather than just leaving voicemails on people's emails where the voicemails are full, they don't hear, they weren't in the office, they never saw the emails that you need to have a meeting and they need to bring things to the table. So the more providers you work with, and that is so extraordinary because you're finding all of those niches of services that are nuanced and that a family may need to reach their goals. You can only imagine that as you're building capacity, you're also you're complicating matters in ways. What are the boundaries for each new provider? What are their service delivery challenges? What are their rules about sharing information and in what format? How do what your need to know and the timeliness of that actually work and are feasible within that agency? We welcome that new agency to the group, but sometimes we don't delve down to find out how they can have the best experience, how their information can most positively affect the team decision making and the ultimate goals for the families. I talked about this in passing. You can do wonderful trainings for the people who are at the table at the beginning of your process, the beginning of your meetings to set up your governance structure, the beginning of the meetings where you are creating memorandums of understanding, your agreements. And then suddenly you have turnover rates of staff. Oftentimes that person just arrives, they have no idea maybe what's going on. We tell them in a sort of quick abbreviated manner, but what are we going to give them? Can we hand them a protocol that they can look at? Will someone from the team reach out to them and go through the protocol with them so they totally understand the communication sharing that we all agreed upon, what's in, what's out, the timeliness, and the format. So we all need to, it's a fact of life in child welfare and in treatment, contingency plans for bringing new folks in from a given agency or a new agency as a whole. We always felt that the more broadly we did trainings in our community where people from many disciplines were invited so they could be sort of learning on a broad basis what it is we were doing as we set up our drug court. What were our expectations? How was it different? Then you can give nuanced training, but people have some idea of the outer framework of what you're working on. We continue to do these trainings at the courthouse at lunchtime. And we have providers come, and a new provider will talk about what they offer and to whom. We will have trainings for that hour from 12 to 1 about drifting from Fidelity, why Fidelity is important. We have discussions about challenges for information sharing. And we do it because everyone's in the courthouse and everybody, for the most part, including the judges, can come at lunchtime. Okay. So we're doing this not because we need more busy work. We're doing it because with this approach and doing our homework in advance, not only are we integrating the services that we're providing and the interventions to the adults and the children, they are going to see how organized we are and that we're not asking them the same questions at every agency. They're going to learn that we're upfront with them, and when we share information with them, we're going to talk about the implications of information that we received about noncompliance, about missing sessions at the parenting. We're not going to blindside anyone. And the fact is that when we anticipate our barriers, create our processes concretely, when we have accountability information that is across the system of care, our collaborative core team can do their best work. And we skipped ahead to that slide, but let us never forget that doing all of this is a major juggling routine. And this slide comes from 40 years ago when people used to go on TV to see how many plates they could balance at the same time. And I'm sure that all of you are balancing so many plates in your roles as members of your collaborative core teams, within your own discipline, at your own agency. But the time for integration is now. That's at the core of family-focused care. And lastly, as Ken said in the chat box, you don't always have to reinvent the wheel. Part of what we do is to share information, share templates that can be manipulated to meet the needs of your families. And even though we won't always get it perfectly, we will be asking the right questions about accountability, evidentiary information, family-centered care, and also greasing the wheels, if you will, to appropriate information sharing while protecting privacy and confidentiality of our families. So thank you.
Thanks, Lynn. Great conversation and presentation. Before we do resources, let me make a couple of comments too. As I mentioned in the chat box, we can help you with developing MOUs. We have MOUs from other sites that we can share with you. We have the full communication pathway template, and so through your CLs, we can work with you on using that template. Not that you fill it out as you see it verbatim, but it's a good way to prompt your team to identify those communication intersections, and then to determine, the what, and the who, and the how often, and how, and that can be worked into your MOU. So we can work with you both in developing MOUs as well as applying a communication template so that you have your own kind of communication map, if you will, that then guides the communication from not only your team members but anyone that may become before the court, as well as agencies outside the court, right? So a number of you are serving participants who aren't necessarily court enrolled, but really the same processes and the same the level of information sharing and those components can be used outside the court as well. The other thing is that what struck me, Lynn, and you were talking about kind of a 9 to 12 month developmental phase and bringing everybody together and deciding which instruments you're going to use. It was a huge investment. No doubt it was, for a place like Miami, a huge investment at the front end. But my guess is, and if you can comment on it, my guess is that in the long run it has saved a tremendous amount of effort and time, both in terms of your provider agencies as well as the court. And I put that out there because we have a window working with all of you, all of you and all of your court teams at the Quick sites. We have a window, and as I reminded our friends in Jefferson County, Alabama, that that we're down to 24 months, and we just, October's done, so now we're down to 23 months together. Take this opportunity to institutionalize, to develop the kinds of processes that we're talking about today within the context of this quick engagement, so that at the end of this engagement, you have these processes in place. You're able to institutionalize them, and then you're able to apply them as providers move in and out of your network, as there's turnover, as Lynn indicated. Make that investment through this engagement in the quick process, and that as you have access to the change team and the consultants. Lynn, do you want to say anything about that?
I think given the timeline that you have clarified, it helps to find a place in the system of care where you want to pilot this process, if you will. What aspect of what you're working on right now would be manageable, where you could do this deep dive, but understanding your limited time frames, and you could draw information as needed to be able to sort of test out how this process and information sharing works on one aspect of what your court team is doing, because it will serve as a prototype and an approach as you move into other areas. You won't be able to do it all at the same time, but I think if you taper it down and you target and say, this is what we want, let's bring accountability and more protocols to this aspect of what we're doing. Let's create a plan where we get our information in a timely way. Let's get ideas from our providers, what would work for them. And then let's, as you were saying, Ken, let's maybe, what we did is we did a survey where we asked providers some questions in general about what were they delivering, was it evidence-based, what is the typical average dosage, just average, what data do you collect on participant progress, and then maybe that's all you're able to do about the larger system of care. Find out where you're at and how you would proceed in the future to address where you see some gaps and build on your strengths.
Great. Thanks, Lynn. I would say that there are two areas of focus for you to be thinking about. One is your primary focus around delivering interventions to families. So if you're a family drug court, that tends to be substance use disorder treatment, and then the parent-child interventions, the parenting program that programs that Lynn has mentioned. If you're an early intervention court, certainly the evidence-based parent-child dyad work, and then as in addition to that, expanding access to substance use disorder treatment. So I put those clinical interventions into one box, if you will, or one cohort. And then the second one is ones that I think most communities that we come in contact with, both within Quick and outside of Quick, is implementing plans of safe care. And that information sharing and how those plans are developed and how those plans move with a parent, move with a woman, move with a pregnant woman or a new mom after giving birth, and how that care gets coordinated, and all this applies to that, and the interventions that woman is receiving, both prenatally at birth and then upon returning home. And so I kind of put that out there for your consideration and thought. Speaking of Plan of Safe Care, upcoming webinars, so we're going to spend some time in December, Jill Grisham sharing with you information about what other jurisdictions, states, and communities, counties around the country are doing around implementing Plans of Safe Care, share with you some of the templates and some of the processes that are being used in various places around the country. We've been talking to Dr. Chasnoff, and we've locked in a date with Dr. Chasnoff in terms of a follow-up discussion, February 6th. We'd like your input around this. We'd like your input. This could go a couple of ways, this webinar. My thinking is that to use this as a way for you to invite your healthcare providers, particularly pediatricians, neonatologists, to a webinar by Dr. Chasnoff. And that could include screening as well as interventions for infants and children affected by prenatal substance exposure. Recall that Dr. Chasnoff is a pediatrician. The other way this can go is a follow-up, as that slide indicates, a follow-up to what Dr. Chasnoff did at the All Sites meeting with some of your already engaged providers. So give us some feedback as to what you think would be helpful. I'm thinking that it would be a way for you to engage healthcare practitioners, and most of you have indicated, we've learned that are challenged with engaging those infant and maternal healthcare providers, and we can have a webinar that you can use to engage them. We're also working on a couple of other webinars. We're not ready to put them up on a slide yet, but we're talking with Mimi Laver from ABA, Center on Children and the Law, around the follow-up to the All Sites meeting, engaging the attorneys involved in your court teams, kind of a community forum, if you will, and discussion around some of the implementation, both innovations as well as challenges they may be experiencing, and then also another component or another engagement process to engage attorneys that may be not involved or peripherally involved, or maybe reluctant to even refer their clients to your specialty court. And so we're looking at kind of a couple of TA opportunities with Mimi and her team and Eva from the ABA. And then the resources slides, you've seen these on site visits, the publications available through the National Center on Substance Abuse and Child Welfare, implemented by Children and Family Futures, supported by SAMHSA and the Children's Bureau. And you see those resources. The one on the bottom in the middle is SAFER, has a communication template, and all these are available online. And then the next one, we talk about some of the discussion today around communication protocols and some of the governance and collaborative structures and processes that are embedded in this collaborative approach document publication that was published by SAMHSA and the National Center back in, I think it came out August of 2016. And so at the conclusion, and then these are the other resources that we included on the last presentation as well, and links to resources related to the discussion in these last two webinars. You know how to contact us. You can contact Dr. Katz directly. You can come through your change liaisons if you'd like, with more specific information or a request that you might have, and you can contact me as well. At the conclusion of the webinar, you'll get a Survey Monkey around this webinar and asking you to provide feedback on what you heard today and help us improve our delivery of these webinars as we plan those over the coming year. We're also interested in your input and suggestions for content areas, topics that we need to present. and also interested in having you present at some point in the coming year and have what we call learning exchange webinars and give you an opportunity to network with your colleagues as quick sites and present some of your innovations as well as some of your challenges and kind of take what we did at the poster session and take that to the next level now that you'll have a time later, over the course of the year to implement some of the practice changes that you've been contemplating and working on in terms of your site action, developing your site action plans. And with that, Lynn, I want to thank you so much for putting these two webinars together. I want to thank all of you who participated today and joined us for your time.
Yes, thank you, everybody.
Thank you. Reminder that both of these are recorded. We gave you the link earlier for the first one. This one should be up within a week, and we look forward to talking to you at the next at the December webinar as well. And I want to thank our team down in Orange County, California, for all your assistance in putting this together as well. Have a good week, everybody. Thank you.